This recording will provide an introduction to burn injury and talk about the different types of burns. Tissue destruction caused by a burn injury leads to local and systemic problems that affect fluid and electrolyte balance and lead to protein losses, sepsis, and changes in metabolic, endocrine, respiratory, cardiac, hematologic, and immune functioning. The extent of problems is related to age, general health, extent of injury, depth of injury, and the specific body area injured. Even after healing, the burn injury may cause late complications, such as contracture formation and scarring. Priorities of care are the prevention of infection and the closure of the burn wound. A lack of or delay in wound healing is a key factor for all systemic problems and a major cause of disability and death among patients who are burned. The skin is the largest organ of the body. It has two major layers, with the epidermis being the outer layer and the dermis being below it. The epidermis can grow back after a burn injury because the epidermal cells surrounding sweat and oil glands and hair follicles extend into dermal tissues and regrow to heal partial thickness wounds. Together with sweat and oil glands and the hair follicles are the dermal appendages, which vary in depth in different body areas. The epidermis itself has no blood vessels, and nutrients must diffuse from the second layer of skin, the dermis. Within the dermis are the blood vessels, sensory nerves, hair follicles, lymph vessels, sebaceous glands, and sweat glands. When burn injury occurs, skin can regrow as long as parts of the dermis are present. When the entire dermal layer is burned, all cells and dermal appendages are destroyed, and the skin can no longer restore itself. With deep burns, the subcutaneous tissues may be damaged, leaving bones, tendons, and muscles exposed. The skin has many functions, including the fact that it's a protective barrier. It plays a role in fluid and electrolyte balance. It's an excretory organ. It allows for us to feel sensations such as pain. When exposed to sunlight, skin activates vitamin D. So all these functional roles that the skin has can be altered with burns. So let's first talk about the protective barrier. So protective barrier in that it protects against injury and microbial invasions. Burns break the barrier, greatly increasing the risk for infection, right? The skin helps maintain the delicate fluid and electrolyte balance essential for life. After a burn injury, massive fluid loss occurs through excessive evaporation. The skin is an excretory organ through sweating. Full thickness burns destroy the sweat glands, reducing excretory ability. The sensations of pain, pressure, temperature, and touch are triggered on the skin in normal daily activities, which allows the person to react to changes in the environment. All burn injuries are painful. With partial thickness burns, nerve endings are exposed, increasing sensitivity and pain. With full thickness burns, nerve endings are completely destroyed. At first, these wounds may not transmit sensation except at wound edges. Despite this destruction, patients often have dull or pressure type pain in these areas. And that's not even getting into then if they're getting treatment years down the road for the problems that they have with the scar tissue from burns. That itself can be painful also. Skin exposed to sunlight activates vitamin D. Partial thickness burns reduce the activation of vitamin D, and this function is lost completely in areas of full thickness burns. I think I forgot to talk about how the skin plays a role in maintaining body temperature. The internal body temperature remains within a normal, narrow range compared to temperatures in the external environment. Skin tissue integrity is important in maintaining normal body temperature. And then finally, physical identity is partly determined by the skin's cosmetic quality, which contributes to each individual's unique appearance. A patient who sustains a major burn often develops reduced self-image and other psychosocial problems as a result of appearance changes. The severity of a burn is determined by how much of the body surface area is involved and the depth of the burn. The degree of tissue integrity loss is related to the agent causing the burn, the temperature of the heat source, and how long the skin is exposed to it. Differences in skin thickness in various parts of the body also affects burn depth. An area where the skin is thin, such as eyelids, ears, nose, genitalia, the tops of hands and feet, fingers and toes, A short exposure to high temperatures causes a deep burn injury. The skin is thinner in older adults, which increases their risk for greater burn severity, even at low temperatures of short duration. Burn wounds are classified as superficial thickness wounds, partial thickness wounds, full thickness wounds, and deep full thickness wounds. The partial thickness wounds are further divided into superficial and deep subgroups. Please review Table 21-6 that goes over the classifications of burn depths. Burns are also classified as minor, moderate, or major, depending on the depth, extent, and location of the injury. Please review the table that also goes over classification of burn injury and burn center referral criteria. Superficial thickness burns are also known as first-degree burns. Superficial thickness wounds have the least damage because the epidermis is the only part of the skin that is injured. So with superficial, we're only talking about injury to the epidermis. The epithelial cells and basement membrane needed for total regrowth remain present. These wounds are caused by prolonged exposure to low-intensity heat, like a sunburn, or short flash exposure to high-intensity heat. Redness with mild edema, alterations in comfort, and increased sensitivity to heat occur as a result. Desquamation is the peeling of dead skin, and that usually occurs 2 to 3 days after the burn. The area heals rapidly in 3 to 6 days without a scar or any other complications. Partial thickness burns are also known as second-degree burns. A partial thickness wound involves tissue integrity loss of the entire epidermis and varying depths of the dermis. Depending on the amount of dermal tissue damaged, partial thickness wounds are further subdivided into superficial partial thickness and deep partial thickness injuries. Superficial partial thickness wounds are caused by injury to the upper third of the dermis, leaving a good blood supply. These wounds are pink and moist and blanch when pressure is applied. The small vessels bringing blood to this area are injured, resulting in the leakage of large amounts of plasma, which in turn lifts the heat-destroyed epidermis, causing blistered formation. Small blisters are often left intact if they are not located over a joint, while large blisters are usually open and debrided to promote healing. Superficial partial thickness wounds increase pain sensation. Nerve endings are exposed, and any stimulation, such as touch or temperature change, causes intense pain. With standard care, these burns heal in 10 to 21 days with no scar, but some minor pigment changes may occur. Deep partial thickness burns extend deeper into the skin dermis, and fewer healthy cells remain. Blisters usually do not form because the dead tissue layer is thick, sticks to the underlying dermis, and does not readily lift off the surface. The wound surface is red and dry with white areas in the deeper parts, dry because fewer blood vessels are patent. When pressure is applied to the burn, it blanches slowly or not at all. Edema is moderate and pain is less than with superficial burns because more of the nerve endings have been destroyed. Blood flow to the area is reduced, and progression to deeper injury can occur from hypoxia and ischemia. These wounds can convert to full-thickness wounds when tissue damage increases with infection, hypoxia, or ischemia. Deep partial thickness wounds generally heal in 2 to 6 weeks, but scar formation results. Surgical intervention with skin grafting can reduce healing time. A full-thickness wound occurs with destruction of the entire epidermis and dermis, leaving no skin cells to repopulate. The wound does not regrow, and areas not closed by wound contraction require grafting. The full-thickness burn has a hard, dry, leathery eschar that forms from coagulated particles of destroyed skin. The eschar is dead tissue. It must slough off or be removed from the wound before healing can occur. These thick particles often stick to the lower tissue layers, making eschar difficult to remove. Edema is severe under the eschar in a full-thickness wound. When the injury is circumferential, completely surrounding an extremity or the chest, blood flow and chest movement for breathing may be reduced by tight eschar. Eschar-otomies, which are incisions through the eschar, or fasciotomies, incisions through the eschar and fascia, may be needed to relieve pressure and allow normal blood flow and breathing. A full thickness burn may be waxy white, deep red, yellow, brown, or black. Thrombosed and heat coagulated blood vessels may be seen beneath the surface of the burn and leave the burn tissue without blood supply. Sensation is reduced or absent because of nerve ending destruction. Healing time depends on establishing a good blood supply in the injured areas. This process can range from a few weeks to months. Deep full-thickness wounds extend beyond the skin and damage muscle, bone, and tendons. These burns occur with flame, electrical, or chemical injuries. The wound is blackened and depressed, and sensation is completely absent. A full-thickness burn needs early excision and grafting. Grafting decreases pain and length of stay and hastens recovery. Amputation may be needed when an extremity is involved.